Hopefully this will be a little bit less dirty lecture than I normally give. I'll be honest, I have about 15 minutes. I found it very harrowing to try and break down one of my fecal incontinence lectures into that amount of time. And I know I see some of my patients in the audience and they know I can speak 100 miles a minute. So if something goes over your head, if it didn't make sense, if I was moving too quickly, again, I will hang around as long as I have to afterwards to kind of clear this up. Okay? So I'm going to be talking about fecal incontinence. And I think, like you'll hear from a lot of the subspecialists today, a lot of our data comes from just standard patient populations. We don't have a lot of good data in our clinical trials for individuals with scleroderma. So I'm going to try and differentiate where there is data in scleroderma specifically as opposed to just the general populations of people that we see. So I think the best place to start is with a definition of fecal incontinence because, again, for those of you in the audience who've seen me, I kind of have a template where I go head to toe throughout the GI tract to try and determine what could be causing GI symptoms. And when I get down to the bottom, I'll usually ask people, do you have fecal incontinence? And they'll look at me like I have 6 eyes and say, what in the world are you talking about? So it's a very vague term. We've tried to change the definition a little bit. There are a myriad of definitions, but quite frankly, fecal incontinence is nothing more than the accidental involuntary leakage of stool out of the anal canal. There are a whole bunch of synonyms. We use accidental bowel leakage, stool loss, accidental stool loss, involuntary stool loss to define this term. And it's becoming more and more common. This is some data from 2 different studies. The one on the top is from a national health study looking at the overall prevalence of fecal incontinence in the general population, and we're looking at about 1 out of 11 individuals. On the flip side, patients with scleroderma, 3 to 4 times more common, and I'll tell you that we think that the prevalence in both populations is probably underrepresented by these numbers because when it comes to this disorder, we take a very much don't ask, don't tell approach. We don't ask. When I go to national meetings around the country, I ask gastroenterologists who've been practicing anywhere between 5 and 50 years. If somebody comes in and tells you they have fecal incontinence, would you know how to diagnose it or work it up? The vast majority of the time I see 1 or 2 hands go up. This is a major issue. The National Institutes of Health is looking into better training and teaching physicians on how to deal with this disorder because it's becoming more and more common. From a patient standpoint, this is a don't tell phenomenon. We have all kinds of good epidemiologic studies that tell us that patients are embarrassed. There's social stigma related to this disorder, so they hide it as opposed to discussing it. And I think historically that was probably an appropriate thing to do because we didn't have a lot that we could do in terms of treating this disorder, but I think as Dr. Kudika said in his lecture, over the last 10 to 15 years, we've had some really good breakthroughs, some less invasive procedures that work very well for treating patients with fecal incontinence at this point. So I was going to bring up all kinds of fancy schematics, and I said, why? It won't make any sense. So what I decided to bring is a picture of the model that I use in my clinic on a day-by-day basis. So this is basically a cross-sectional representation of your pelvic floor. And I really want you to focus on 3 major end organs here. The first is the external anal sphincter. This is the muscle at the bottom. It's skeletal muscle. It's just like the muscles in your hands and your feet. If you want to contract your hands into a fist, you can do that anytime you want. If you want to contract the muscles down there, specifically the external anal sphincter, you can do that as well. This is the muscle you engage in the bottom when you're doing Kegel exercises. But it's also the muscle that you use to keep stool in when it's inappropriate or you get that urge to go to the bathroom when you're not in the right place. So what I usually ask my patients is this. Do you ever notice that you're in the middle of the mall, you get that urge like you have to have a bowel movement, and you can't make it to the bathroom on time? And that's usually related, if they say yes, to some breakdown in the structure or the function in this muscle. I say the gotta go right now, can't get there on time phenomenon. When people tell me that, it's associated with a type of incontinence known as urge incontinence. I have the urge, I can't make it. And again, specifically associated with damage to the structure or function of this muscle. The second muscle is the internal anal sphincter. This is the one that's damaged most frequently in patients with scleroderma. Scleroderma affects the smooth muscle of the GI tract, and this is a smooth muscle. This is the one that's responsible for the vast majority of your ability to keep stool in at rest. So when you're at work every day, when you're out jogging, when you're sleeping, stool does not come out because this muscle is your best friend. But when this muscle breaks down, people will develop a type of incontinence known as passive fecal incontinence, and they will come in and say, I don't know until after the fact. I'm sitting at my office working on the computer, I wake up in the middle of the night, and stool has just leaked out. It's associated with the damage to the structure or function of this muscle. And then there's the rectum. The rectum plays a role in sensation and both compliance. This is the muscle that gives you that urge to go to the bathroom. When stool makes its way through your GI tract and gets down to the rectum and distends the rectum, you get that urge like you have to go, and you decide if it's the right time or the wrong time. This is where we look at stool characteristics, constipation and diarrhea. For patients who've had long-standing constipation, which we can see with scleroderma because there's delayed transit throughout the GI tract, they get a lot of stool that stretches the rectum out. It can take a long time to go to the bathroom. Over time, this very compliant organ becomes very boggy, very flaccid, and it takes more and more stool to stretch the rectum to give you the urge to go to the bathroom. When hard stool sits at the bottom in the rectum, the stool above it becomes very loose and can leak out, and this gives us a type of incontinence known as overflow incontinence. A lot of times I see patients, they come in and they're actually saying they're having diarrhea. They're going to the bathroom 10, 15, 20 times a day, and I'll ask how much, and they'll say little squirts of stool, and I'll say, do you strain? Yes. Do you feel like you're not getting everything out? Yes. Are you taking antidiarrheals for this? Yes. It's the wrong way to go. It's actually constipation that's causing the problem. On the flip side, if there's inflammation to the rectum, which can be seen with things like Crohn's or ulcerative colitis, if you've had radiation to the pelvic floor with something like uterine or prostate cancer, for patients who have irritable bowel syndrome, then we see a hypercompliant rectum. This rectum does, a hypocompliant rectum, a hypersensitive rectum. The rectum doesn't stretch as much. You get that urge to go over and over and over again. We know that diarrhea, when it comes to fecal incontinence, is our biggest enemy. When we look at risk factors for fecal incontinence, diarrhea is the #1 risk factor. You are 55 times more likely to develop fecal incontinence if you have diarrhea than the average person would. And this risk factor is 15 times more likely to cause incontinence than anything else that we know as a risk factor to this point, which is also a good thing because we can treat diarrhea. So if we find the underlying cause, it usually goes away. And again, in scleroderma, and Dr. Khanna may talk about this a little bit later, people can develop bacterial overgrowth, which can lead to a multitude of diarrheal syndromes. So when we look at subtypes, we talked about a few of these. Again, this is just a schematic for you to take home. Again, at the top, passive. I can't control it. It comes out. It's involuntary. I have no rhyme or reason or warning that this is going to occur. Related to that internal anal sphincter. Urge at the bottom at 6 o'clock. Gotta go, can't get there right now. Related to the external anal sphincter. Overflow, I'm constipated and it's leaking out, and then there's stress, which is very much like stress urinary incontinence, which women get after they have childbirth. I cough, I sneeze, I laugh, and stool comes out. There are 2 other subdomains. We talk about fecal seepage. This is usually seen in men. A little bit of stool comes out every time they go to the bathroom and sits around the anal verge. This can happen multiple times a day. They end up in the bathroom wiping over and over and over again. And then there's fecal soiling, where you get a few drops or a few streaks of stool in your undergarment. This is some common deficiencies that we see in scleroderma patients. This is beyond the scope of the time that we have today, but again, just wanted this to be in your slide deck so you can take a look at it. You'll see there are neurologic processes that play a role here, muscle processes and the structure and function, and then the stool characteristics, all of which can be seen in patients with scleroderma. How do we go about working this up? It's very simple. Take a history, I do a physical exam, and then there are a few diagnostic tests if I don't know what's going on. I'm pretty much sure of what's going on after I take the history and the physical, but I want to walk you through some of the diagnostic studies because we do use those, and I want you to see what those are like and what they give us. So this is the template I use in my own clinic. When somebody comes in, they say they have fecal incontinence. Very simple. How long have you been dealing with it? How often does it occur? What is your stool texture? Again, I'm looking for hard stools versus loose stools, and there's a Bristol stool scale, which I bring up on my clinic, which shows you things that look like stools that range from milk duds to water with everything in between. And that helps me figure out how to treat you. I won't give you the in-betweens right now. What's the severity? I'm looking at the quality of life. Does this happen once a month? Is it more of a nuisance than anything else? Or is this something that occurs 2 to 3 times a day where you're so afraid to leave your house, you quit your job, you're trying to obtain disability, you no longer travel, you no longer meet with friends for dinner? We look for the different subtypes. I can usually get that from your clinical history, and then there are other risk factors that I will ask about. When we talk about the physical exam, it's a digital rectal exam. That's where my finger is my best friend and your worst enemy. Okay? I look at 2 different types and parts of the exam. The first part is an external inspection. I'm looking for breakdown at the anal verge, skin breakdown. Do you have leakage? Is the stool starting to burn the tissue? There are different ways that we can treat that. I look for hemorrhoids or fissures, little cuts and tears in the sphincter muscles that can break continuity in those muscles that lead to leakage. I'm looking to see if the pelvic floor descends appropriately when I have you kind of push. People are really afraid to do this. My head is back there down by your rectum, and I'm saying push, and you're saying, are you kidding me? Which is how I get away with wearing my pajamas to work every day, because I can justify it to my colleagues. Guys, look, I'm going to go hold with a stool on my side 3 days a week. What am I going to do here? The internal exam, again, my finger's my best friend, your worst enemy, but it helps us make a diagnosis. I'm looking for muscle tone. When I put my finger in there at first, I can feel the strength of that internal anal sphincter, the one that controls continence at rest. I will have you squeeze down against my finger. I'm looking at how strong you squeeze and how long you can maintain that. And if one or both of those are deficient, I know you're going to have difficulty getting to the bathroom when you get to the urge. And then I do a few other maneuvers to test the pelvic floor to see if I think there's a constipation-related disorder that needs to be treated. Because this constipation disorder is treated completely differently than anything else. It's not medications, it's not injections, it's not surgeries, it's physical therapy. We can talk about that in clinic. When I'm not sure I have these three tests, I stick pretty much to the top two. The first is anorectal manometry. I have two separate catheters. The catheter on the left is the one I use most commonly. This is my high-resolution catheter. It has two copper sensors at the top. These are pressure sensors, 10 across the anal sphincters. And again, these can tell me your sphincter tone, how well you squeeze, how strong your squeeze is, how long it's maintained, how compliant or sensitive your rectum is. Like I was showing you in that initial slide, that gives me all the information I need to try and figure out what's going on. If I think there's just asymmetry to the muscle, I can put the bigger catheter in there, which is my high-definition catheter. This gives me 3D views of the sphincter complex all the way around. It has 200-plus sensors, and I can see if there are site-specific deficiencies, because at times I can target those. This is an example of what I can see when I put the high-resolution catheter, the one on the left, in. This would be a patient with normal resting tone. This would be a man. These are color topography plots. And at rest, the person's just laying there on their left side, and I'm seeing the internal anal sphincter. This is about 80 to 90 millimeters of mercury, which is normal. On the right side, this would be somebody with scleroderma. I'm seeing about 5 to 10 millimeters of mercury at rest. This would be somebody that I'm concerned about passive fecal incontinence. This is somebody where after this catheter test, I'd want to go back to my history and say, did I see this individual tell me that they're having involuntary loss of stool without their knowledge? This is the endoanal ultrasound. This is done very much like a colonoscope or a flexible sigmoidoscope. If any of you have had that, we put a probe in, but instead of having a very fine camera at the end, it has an ultrasound probe. We see both parts of the muscle. The external anal sphincter is this hyperechoic process, the circle around here. The internal anal sphincter is the hypoechoic or black circle. And in patients with scleroderma, what we see is thinning, atrophy, and fibrosis of this muscle over time. So on the right would be somebody with scleroderma, and you can see the differences in size here. And again, this would put somebody at risk for passive incontinence. How do we treat this disorder? A few different ways. It depends on how severe the disorder is for you. If you're having a little bit of anal leakage or anal seepage, this may sound crazy, but your best friend is a cotton ball. You can put it right up there at the anal verge. It will collect that seepage. It will keep the skin safe. It will keep it from leaking into your undergarments. It works very, very well. It does not work very well for people with overt incontinence where they're having full bowel movement accidents. You can use enemas. Enemas are a safety valve. Remember, you have a lot of stool that's being stored in your rectum. If you need to go out for 2-3 hours, you're getting on a plane, you want to go to a bar mitzvah or a wedding, you can clean out your rectum, get all of that stool out of there using an enema. It will give you the confidence there's not going to be anything left there to leak, because the remainder of the stool is being stored on the right side of your colon. It will give you time to respond. Biofeedback is one of the best things we have. This is done by our physical therapists. They can use probes like the ones I just showed you. They will show you how to strengthen those muscles so that you can maintain stool more appropriately. In terms of medications, very simply, when you look at the average population, there are no randomized double-blind placebo-controlled studies, which are the gold standard studies for treating this disorder, for any of the medications we've tried. In scleroderma, obviously, then we don't have any either. However, I will tell you that I wholeheartedly believe, and in clinical practice I have seen and shown, that if you come in and your predominant risk factor is diarrhea, if I can reverse the diarrhea, the fecal incontinence will go away. When these fails, we have a couple of other very good, less invasive, and by less invasive I mean non-surgical procedures that we can offer. This is one called the Celesta Injection. It's a combination of these microscopic beads and a hyaluronic acid or gel polymer. This is FDA approved for women with fecal incontinence over the age of 18 who failed other therapies. This is simply done in the office. It sounds like a surgical intervention. It's not. I do it up in my own clinic. It takes me about 10 minutes. There are 4 syringes. We have you lay on your left side. We put it in an anoscope. We go above a line. There's a line that separates the outside of the anal canal from the inside. And above that line, there are no pain receptors. We do these small injections. We do 4 injections, which bulk the anal canal, which narrows it. And this is a very simple process. You walk in, you walk out within a half hour. This was the clinical trial that got it approved. It was called the NASHA DX study. In this study, they brought patients in and they either injected them with this Celesta solution or they did a sham, they put the needle in, or they didn't inject anything. And the primary endpoint that was looked at was the percentage of individuals that had a 50% reduction in their fecal incontinence episodes or in their accidents at 6 months. And you can see about 1 out of every 2 individuals who got this therapy had that 50% reduction, with a number needed to treat of about 5. So it means that 1 out of every 5 individuals is going to get this response, because there is a placebo response. If you look at some newer data that comes out of Europe, we now know that about 2 out of every 3 individuals that get this injection will have this 50% reduction out to 3 years' time. Now, people always ask me, why do you cut off at 50%? You know, why don't we look for something better? That's what the FDA was looking for in these clinical trials. Another interesting piece, look at baseline. At baseline, the people enrolled on average were having about 2 bowel accidents a day, and by 6 months, this was reduced by 60% to less than 1. So we do get some very good outcomes from a very low-risk, non-invasive procedure. When this fails, the next step we like to take is the use of a sacral nerve stimulator. The best way I can make an analogy on this one is to the cardiac pacemaker. If anybody's ever had a pacemaker put in, it looks like this. It usually goes up in the left anterior chest wall. It's connected to 2 leads. This is a 2-step process. We want to make sure it's going to work for you. Step 1 in the office, we can place these 2 little leads into the back, into the sacral nerves. These are the nerves that innervate the internal external anal sphincter. You wear the battery pack on your side. You come back in 2 weeks, and we're going to ask you the same question as the other trial. Did you notice that you had a reduction in your fecal incontinence or your bowel accident episodes by 50%? If you say yes, we make a small pocket just at the upper portion of the hip under the skin. We implant that battery pack. It stays there for the next 10 years. There's some very good data in clinical trials looking at the efficacy in patients who have received this who don't have scleroderma. I'll tell you that about 65% of individuals have a 75 to 100% reduction in their fecal incontinence episodes at 12 months. This is the data what we have in scleroderma. We've looked at 5 patients. On average, these patients were having at least 2 episodes of fecal incontinence a day. They'd had scleroderma for 13 years and fecal incontinence for at least 5 years. Here's what we saw. Unfortunately, in the first person, the leads fell out in the first 24 hours in a clinical trial. You don't put them back in. For the other 4 individuals out to 5 years, there was a complete elimination of fecal incontinence episodes or accidents. They regained complete continences, and this is something we're looking into. Also, we noticed significant decreases in urgency, so that sensation like you have to go very quickly was reduced, and quality of life was significantly increased. The physiologic correlate, the resting pressure, the one that's that internal anal sphincter, the one I told you controls your stool at rest, increased in all of these individuals. So that's how we think the muscles are working. So in summary, fecal incontinence is a common and debilitating disorder. It's due to anatomical and functional pelvic floor deficiencies as well as changes in stool characteristics. I wanted you to be aware of the different subtypes because I ask all the individuals I talk to about this what subtype they may have. When it comes to diagnostic studies, step 1 is the finger, step 2 maybe the manometry or the ultrasound. And again, none of these treatments as of right now is a panacea, but they are working much better and we are getting rapidly improving outcomes. Thank you very much.